You're listening to Who Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about aortic stenosis. We'll go over the presentation, grading the severity, invasive hemodynamic measurement of aortic stenosis, and we'll save the management for a future episode since there's so much to cover. Since this is the first valvular episode, we'll also spend time at the start talking about the epidemiology of valve disease and the definitions of valve disease stages across all valvular disease, not just aortic stenosis. So let's start with the epidemiology of valvular disease. In industrialized countries, less than 2% of the population, less than 65 years of age, have valvular heart disease, whereas 8.5% of the population 65 to 75 years of age does, and 13.2% of the population above 75 years old does. So it increases quite steeply in the 60s and 70s. In the United States, the most common valvular disease is aortic stenosis, followed by mitral regurgitation, followed by aortic regurgitation, tricuspid regurgitation, and mitral stenosis. Pulmonic stenosis, pulmonic regurgitation, and tricuspid stenosis are rare in adults, comprising less than 1% of adult valvular disease. 60% of rheumatic fever patients will eventually develop cardiac involvement. Rheumatic disease is very common in developing countries, not in the United States. Among rheumatic mitral disease, 25% present with isolated mitral stenosis, 40% present with mixed mitral stenosis and mitral regurgitation. Mitral stenosis is the valve disease that benefits the most from transcatheter balloon valvuloplasty. Mitral annular calcification is a common finding, seen in 45% of the population above 65 years of age. Mitral annular calcification can be associated with either MR or MS in later years. The prevalence of functional mitral regurgitation has now exceeded that of primary mitral valve disease. Both pulmonic regurgitation and tricuspid regurgitation are common echo findings. Usually, nothing needs to be done about that if it's mild. Most tricuspid regurgitation is functional, resulting from pulmonary hypertension, either primary pulmonary hypertension or left heart disease related pulmonary hypertension, or resulting from RV dysfunction from biventricular cardiomyopathy or volume of overload resulting from an intracardiac shunt. Organic primary valvular TR is relatively uncommon. Non-organic primary valvular TR can occur from pacemaker or ICD wires crossing the tricuspid valve, causing valve entrapment or injury. Tricuspid stenosis is almost never seen, except in 3 cases: rheumatic heart disease that already has had mitral valve and aortic valve involvement, prosthetic valve dysfunction, or some carcinoid syndrome. Carcinoid syndrome patients can have a frozen tricuspid valve with simultaneous tricuspid stenosis and tricuspid regurgitation. Pulmonic regurgitation is almost always secondary to pulmonary hypertension. Rarely, pulmonic regurgitation can be from repair of tetralogy of Fallot, dilated pulmonary artery, bioprosthetic or homograph pulmonary valve dysfunction, or carcinoid disease. Pulmonic stenosis is rare. It is only seen in rare cases of carcinoid, rare cases of rheumatic heart disease, or radiation injury. The R in AVR usually means replacement of the aortic valve, whereas the R in MVR usually means repair of the mitral valve. Now, in terms of definitions of valve disease stages, the ACC/AHA guidelines sort all valve disease stages into A, B, C, and D across the different types of valves. A stands for at risk. It's for patients with risk factors for development of valvular heart disease who don't have it yet. B is progressive, so it refers to patients with mild to moderate severity and asymptomatic valve disease. Stage C and Stage D are the ones you're going to deal with the most. Stage C refers to asymptomatic severe. Asymptomatic patients who have criteria for severe valvular heart disease can be Stage C1 or C2. C1 is asymptomatic patients with severe valvular heart disease in whom the LV or RV remains compensated. C2 is asymptomatic patients with severe valvular heart disease with decompensation of the LV or RV. Stage D is symptomatic severe, patients who have developed symptoms as a result of valvular heart disease. Each of the above will have its own dedicated episode. So now let's jump into aortic stenosis. Presentation of aortic stenosis. In the absence of intervention for aortic stenosis, the time of death following symptom occurrence is on average 5 years from angina, 3 years from syncope, and 2 years from new onset heart failure. This is the classic teaching from the studies done many decades ago before there were modern therapies. The most common early symptom in aortic stenosis is a decrease in exercise tolerance and dyspnea on exertion due to reduced left ventricular compliance and limited ability to increase cardiac output with exercise. Syncope occurs in aortic stenosis due to exertion in the setting of systemic vasodilation with reduced vascular tone and fixed cardiac output. Symptoms of heart failure such as orthopnea, PND, and pulmonary edema occur later in the course of aortic stenosis. Heyde syndrome refers to the phenomenon in AS whereby shear stress induced platelet aggregation by the stenotic aortic valve causes reduction of high molecular weight multimers of von Willebrand factor and an increased number of proteolytic fragments. This leads to angiodysplasia and GI hemorrhage. Now let's hone in on auscultation and physical exam findings of aortic stenosis. The timing of the aortic stenosis murmur is going to be systolic from S1 to A2, but you don't call it holosystolic. The character is going to be harsh and crescendo decrescendo, meaning a diamond shape. The location will be at the second right intercostal space. You can ask the patient to lean forward to make it more prominent. It radiates and causes what we call pulsus, parvus, et tardus, a diminished and delayed carotid upstroke. Sometimes you can also hear the aortic stenosis murmur at the apex at a higher pitch called Gallavardin phenomenon, which we'll talk about shortly. Mild AS peaks in early systole. Severe AS peaks late in systole. So the later the peak, the more severe the AS. In terms of maneuvers, the AS murmur is decreased by hand grip, which increases afterload. The AS murmur is increased by squatting and leg raise, which increases preload. And the AS murmur is decreased by standing and valsalva, which decreases preload. Pulsus parvus et tardus, which I mentioned, is a small pulse with a delayed systolic peak. It is best evaluated by palpating the carotid artery rather than a peripheral vessel such as the brachial artery. In patients with severe AS plus congestive heart failure, the delayed upstroke is not usually evident, leaving only pulsus parvus. The Gallavardin phenomenon, or Gallavardin dissociation, is a physical exam finding in which elderly patients with aortic valve stenosis will have their holosystolic murmur at the apex instead of the right upper sternal border, thus mimicking the murmur of mitral regurgitation. To determine if the apical murmur is indeed due to mitral regurgitation or radiation of the murmur of aortic stenosis, do hand grip exercises to increase afterload. Hand grip will increase the murmur of mitral regurgitation, but will not change that of aortic stenosis. The murmur of aortic stenosis also increases with bradycardia or after a pause, such as after a PVC. An MR murmur would not change after a PVC. Now let's move on to grading severity. The peak velocity cutoffs for mild, moderate, and severe AS are less than 3.0 and 4.0 or higher meters per second. Those are the peak velocity cutoffs for mild, moderate, and severe AS. The mean gradient cutoffs for mild, moderate, and severe AS are less than 20 and 40 or higher millimeters of mercury. The index aortic valve area cutoffs for mild, moderate, and severe AS are 0.9 and 0.6 centimeters square over a meter square. The dimensionless index is a measure that is the LVOT-VTI divided by the AS-VTI. So dimensionless index is the velocity time integral of the flow through the left ventricular outflow tract divided by the velocity time integral of the flow through the aortic stenosis. The cutoffs for mild, moderate, severe AS in terms of the index dimensionless index are 0.5 and 0.25. So more than zero point 0.5 means it's mild AS, and less than 0.25 means that it is severe AS based on this index dimensionless index. Use of the continuity equation to estimate aortic valve area requires using the LVOT diameter, which is the largest source of errors in aortic valve area calculations due to the inherent difficulty associated with measurement in the presence of a heavily calcified valve, with the area and the error being squared. A 10% error in measurement of the radius results in a 19% error in the aortic valve area measurement. Significant aortic stenosis usually has outflow velocities of 3.5 millimeters per second or greater, which is out of the range for quantification by PW Doppler, but still be able to be quantified by CW Doppler. The use of non-imaging probes, which is PDOF probes, in aortic stenosis allows for ultrasound interrogation from a better position and better alignment of the Doppler signal with the direction of blood flow. In 30% of patients, the highest velocity for aortic stenosis are obtained in views other than apical ones, such as right parasternal or suprasternal. So, if you are presented with aortic stenosis velocities, gradients, and VTIs in other views, you must look at them and take the highest one. When using the right parasternal view to Doppler interrogate the aortic stenosis severity, you must pay attention to not mistake the mitral or tricuspid regurgitant flow velocity for the forward transaortic flow velocity. Measure the duration of the flow in both the apical and right parasternal views. If the duration of the CW Doppler is similar in both views, such as 350 milliseconds and 340 milliseconds, that can provide reassurance that the flow velocity recorded in the right parasternal view is indeed the transaortic view, and the view is showing the actual gradient. If TTE already demonstrates that AS is severe, there is no indication for the butyl stress echocardiogram or TEE. That is what we have for the presentation and grading severity of aortic stenosis. Now we'll talk about invasive hemodynamic measurement for aortic stenosis, including Gorlin and Hakki's formula for aortic valve area. In 1951, Richard Gorlin, together with his father, who was a mechanical engineer who designed hydraulic systems for gas engines, published their formula for calculating aortic and mitral valve areas. Gorlin's valve area equals cardiac output divided by all of the following: heart rate times either the diastolic filling period or the systolic ejection period times 44.3 times a constant C times the square root of mean delta pressure. At the top, we have CO, cardiac output. At the bottom, we have HR, heart rate. DFP is the diastolic filling period, or SEP is the systolic ejection period, depending which valve you're looking at, and cath lab software will measure that for you. The constant 44.3 is the blood acceleration factor K, which is the square root of twice the gravity acceleration factor of 9.8 meters per second. So 44.3 comes about just from the square root of 2 times 9.8 meters per second square, 2 times the gravity acceleration factor. Gorlin's formula can be used for estimating the area of not just the aortic valve, but also the mitral and pulmonic valves. For mitral area calculations, the same formula is applied except a correction coefficient of 0.85 is added. For aortic and pulmonic valve area calculations, C equals 1 instead of 0.85 and just disappears. The mean delta P is the mean aortic valve gradient. For the mitral valve area, for the mitral valve gradient, since LA pressure is usually not directly measured, the PCWP, pulmonary capillary wedge pressure from the right heart cath, is used as a substitute for LA pressure and is subtracted from the LV diastolic pressure to obtain a mean pressure gradient. Cath lab software will actually take the integral of the differential area throughout the diastolic filling period to calculate the mean LV PCWP pressure difference to use in place of the mean delta P. Beware that because flow in the Gorlin equation and also the Hakki equation below is assumed to be forward systemic cardiac output, the presence of regurgitation across the valve in question will result in a falsely low numerator, therefore resulting in an underestimation in the calculated valve area. All variables are subject to measurement error, but because the mean pressure gradient is square rooted, errors in measurement and cardiac output have a higher impact on the calculated valve area than errors in measurement in the mean pressure gradient. Then in 1981, Hamid Hakki, who was a fellow under Ami Iskandarian at the time, pointed out that heart rate times systolic ejection period times 44.3, the Gorlin constant, was almost always a number close to 1. So it was possible to simplify the formula. By Hakki's formula, valve area is just cardiac output divided by the square root of the peak-to-peak pressure gradient. Hakki's aortic valve area is just cardiac output over square root of delta peak. So just two variables. Although it is not written in the formula, you must remember to multiply by the correction factor C equals 0.85 in the denominator if you are applying this formula to the mitral valve instead of the aortic valve. Peak-to-peak pressure gradient refers to the peak LV systolic pressure minus the peak aortic systolic pressure. However, because the peak aortic pressure and the peak LV pressure do not actually occur simultaneously, cath lab software will take the integral of the differential area throughout the entire systolic ejection period to calculate the mean aortic valve area to use in place of the delta P peak. Let's go over echo versus cath estimation of gradients. Favorite topic among imagers and interventionalists. Crossing a stenotic aortic valve with a catheter carries increased risk of cerebral emboli in patients with severe AS, so it should only be done when more info is needed. Doppler echo may underestimate the transvalvular velocity and gradient, and thus the severity of stenosis due to misalignment of the Doppler beam with transvalvular flow direction. But Doppler rarely overestimates the velocities and gradients. So, if your Doppler velocities and gradients are already in the severe range, there's no need to dip your catheter through a severe aortic stenosis valve. If there is discordance between Doppler and 2D echo evaluation of stenosis severity and the patient's symptoms, then that will be an indication to perform stenotic aortic valve crossing with a catheter. Doppler echo and cath do not measure the transvalvular aortic stenosis gradient at the same location. Doppler echo measures the transaortic velocity at a vena contracta, where the pressure gradient is a maximum. Cath measures the gradient a few centimeters downstream at the vena contracta after pressure recovery has occurred. At the stenotic aortic valve, blood velocity is highest and pressure is lowest. Once you get past the stenotic aortic valve, the blood slows and you get an increase in blood pressure and a corresponding decrease in the pressure gradient compared to the LV pressure. Because echo does not measure pressures beyond the stenotic aortic valve, but at the level of the stenotic aortic valve itself, it does not account for the pressure recovery in the supravalvular area, which would lessen the pressure gradient between the LV and the supravalvular area. That is one reason TTE is constantly overestimating the transaortic valve gradient compared to cath. The pressure recovery phenomenon, which is the cath finding that the aortic actual measured transaortic valve gradient is not as high as the echo estimated transaortic gradient, is more pronounced in patients with a small ascending aortic diameter of less than 3 centimeters, i.e., in patients with small stature. It's also more pronounced, this pressure recovery phenomenon, in aortic coarctation or fixed obstruction in the proximal ascending aorta. In measuring aortic valve gradients for aortic stenosis for calculating the aortic valve area by the continuity equation, pressure recovery phenomenon would cause overestimation of aortic valve gradients by echo, not underestimation. Aortic regurgitation would also cause overestimation of aortic valve gradients. Overestimation of LVOT diameter always overestimates the aortic valve area. Acute hypertension during a time of catheterization will increase the LV afterload, decreasing LV outflow, causing the AS gradient to be lower than it was on echo. The presence of chronic anemia would increase transaortic valve gradients in aortic stenosis, but the increased gradient should occur on both echo and cath. The simplified Bernoulli equation delta P equals 4V squared is a simplification of the convective accelerative term in the original Bernoulli equation. half rho times the brackets v squared 2 minus v1 squared. Sorry, v2 squared minus v1 squared. Given the blood mass density of 1,060 kilograms per meter cube, half of 1,060 kilograms per meter cube simplifies to 4 when converted for expressing blood pressure in millimeters of mercury units. When there's significant anemia, blood mass density will be lower, so the coefficient is actually lower than 4. There will be an overestimation of the aortic stenosis pressure gradient if the coefficient 4 is applied. When we use the simplified Bernoulli equation instead of the full Bernoulli equation, we are still adhering to the law of conservation of energy, pressure and kinetic energy, except we are only using the convective acceleration term. We are ignoring the flow acceleration term and the viscous friction term because we assume that they are negligible. The presence of a high output state such as fever or dialysis fistula would increase transaortic valve gradients in aortic stenosis. The reason fever or dialysis fistula increases the transaortic valve gradients is that in the original Bernoulli equation, half times rho times brackets of v2 squared minus v1 squared, the v1 is no longer negligible. Oversedation during cardiac catheterization can decrease the transaortic valve gradient, but the effect is usually not large. When people talk about the peak-to-peak gradient on cath of aortic stenosis, you have to remember that the peak pressure on the LV curve does not occur temporally at the same time as the peak pressure of the aorta curve. Because the peak transaortic and peak LV pressures occur at different times, this derived pressure gradient cannot be obtained by echo, since echo can only obtain pressure gradients at a particular point in a given time. Echocardiographic estimation of the peak aortic gradient is more accurate than cath estimation, as echocardiographic estimation reflects instantaneous pressure differences between the aorta and the LV. The pullback method on cath generally overestimates the peak and mean gradients and thus the AS severity because of the space occupied by the catheter within the aortic valve orifice, making the orifice seem smaller than it is. The simultaneous measurement of LV and aortic pressures is preferred for accurate measurement of peak and mean gradients by cath, especially if there's AFib. The peak-to-peak aortic stenosis gradient that is measured by cath and not measured by Doppler echo approximates the mean gradient that is measured by echo. If you're asked to calculate the peak instantaneous gradient across the aortic valve and you're given the LVOT peak PW velocity, for example, 2 meters per second, and you're given the aortic valve peak CW velocity, for example, 4 meters per second, the simplified Bernoulli equation delta P equals 4 Vmax square assumes that Vmax is significantly greater than the proximal velocity across a stenosis and that a proximal velocity is less than 1.5 meters per second. If these assumptions are false, for example, LVOT velocity is around 2 meters per second or higher, then the proximal velocity has to be included in the calculation, i.e., delta P is 4 times Vmax square minus Vprox square. So delta P equals 4 times the brackets of 4 square minus 2 square, or 4 equals 16 minus 4, or 4 times 12 equals 48 millimeters of mercury, is the peak instantaneous gradient across the aortic valve. But if you are asked to calculate the mean pressure gradient across the aortic valve instead of the peak instantaneous gradient across the aortic valve that I just went over, then you cannot use the coefficient 4. You have to use the coefficient 2.4, i.e., mean pressure gradient across the aortic valve is 2.4 times Vmax square, whereas peak instantaneous gradient across the aortic valve is 4 times Vmax square. And as I said, if the LVOT velocity is 2 meters per second or higher, then you cannot ignore it. So then the equation becomes delta P equals 4 times all the brackets of Vmax square minus Vprox square. So going back to mean pressure gradient across the aortic valve, where we use 2.4 times Vmax square. An example, if you are given that Vmax across the stenotic aortic valve is 4 meters per second, then the peak transaortic pressure gradient is 4 times 4 square. equals 64 millimeters of mercury, and the mean transaortic pressure gradient is 2.4 times 4 square equals 38 millimeters of mercury. Alternatively, you can get the mean pressure gradient across the aortic valve by just multiplying 0.64 with the peak pressure gradient across the aortic valve. For example, if the peak aortic valve gradient is 71 millimeters of mercury, then the mean gradient is 0.64 times 71 millimeters of mercury equals 45 millimeters of mercury. If you are presented with a CW image and you have to decide whether it represents the downward hump of aortic stenosis or the downward hump of mitral regurgitation, since the echo boards will often get rid of the thumbnail and you just have to figure it out without the thumbnail. MR would have temporal continuity of the systolic MR signal with the diastolic mitral inflow signal. In contrast, aortic stenosis cannot have temporal continuity between the systolic AS signal and the diastolic mitral inflow signal because the ejection period is flanked by isovolumic contraction and relaxation periods. So remember, AS has no temporal continuity between the systolic AS signal and the diastolic mitral inflow signal because the ejection fraction is flanked by isovolumic contraction and relaxation periods. When you are measuring the mean pressure gradient across the aortic valve in aortic stenosis, high flow states like aortic regurgitation, anemia, and infection cause a higher than expected mean gradient. I mentioned that already. Now, the valvulo-arterial impedance, ZVA, is a measure that estimates LV afterload, summing the effect of the valve and the arterial component. So ZVA is, in the numerator, systolic blood pressure plus mean pressure gradient across the aortic valve, and in the denominator is stroke volume index. So once again, valvular arterial impedance is systolic blood pressure plus mean pressure gradient across the aortic valve all over stroke volume index. And this is a measure that estimates LV afterload by summing the effect of the valve and arterial components. That's all for conventional aortic stenosis. The later half of this episode was very much focused on concepts that will appear on the echo board exam and may not necessarily play a prominent part in the general cardiology board exam. So don't worry too much if those numbers were confusing to you and you're not taking the echo board exam. In the next episode, we will talk about low gradient, bicuspid, unicuspid, subvalvular, and supravalvular aortic disease. After that, we will talk about management with aortic valve replacement in the next episode.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.